Welcome to this explainer. Today, we're putting on our clinical detective hats. We're going to master some core maternal, newborn, and women's health concepts by identifying dangerous cues and prioritizing care. We'll be separating those expected, benign findings from the critical red flags that signal malignancy, hemorrhage, infection, or serious cardiovascular events. So, let's get right into it. Okay, let's kick things off with a fundamental question. Picture this. A patient presents with chest pain, heavy bleeding, or maybe a newly discovered fixed breast mass. What needs your immediate attention first? When you're faced with multiple high-stakes clinical scenarios, how do you decide what to do? Well, that precise clinical reasoning is exactly what we're going to build today. Here is our roadmap for today. We're looking at 1. Triage and red flags. 2. Breast and pelvic alterations. 3. Menstruation and menopause. 4. Infertility management. 5. Reproductive infections. And 6. Interventions and care. Starting off with Section 1, Triage and Red Flags, the master priority. Think of this as your 30-second priority ladder. This is your master guide. Step 1 is absolute. You have to stabilize acute issues like severe hemorrhage, sepsis, stroke signs, or suspected ovarian torsion before anything else happens. You literally cannot address fertility goals or routine symptom control until you've stabilized the patient's immediate hemodynamics and any life-threatening concerns. Now, this is absolutely crucial. When evaluating these urgent threats, remember that women often present with atypical cardiovascular symptoms. Cardiovascular disease is a major cause of death in women, yet we're so often just looking for that classic elephant sitting on the chest presentation. We have to treat sudden, profound fatigue, dyspnea, nausea, or jaw and back pain as potential ischemia. Never ever dismiss these subtle symptoms as just stress or anxiety without a proper assessment, which includes an ECG and checking troponin levels. Moving right along to Section 2, breast and pelvic organ alterations, and how we handle systemic investigations. When breaking down breast findings, it's all about pattern recognition. Fibrocystic changes are usually bilateral, tender, and cyclic. A fibroadenoma, on the other hand, is typically firm, mobile, and painless. Then you have mastitis, which brings localized heat, erythema, and a fever. But pay close attention to cancer. A hard, irregular, fixed mass, which is often painless and maybe has skin dimpling or a peau d'orange texture. That is a massive red flag. A hard, fixed mass is a cancer cue until diagnostic imaging and biopsy prove otherwise. All right, shifting down to the pelvis. When evaluating pelvic organ prolapse, which is often caused by childbirth trauma or aging, it is incredibly vital to connect the anatomical shift with the patient's actual symptoms. An anterior vaginal bulging pressing against the bladder, that's a cystocele, characterized by urinary frequency or retention. Conversely, a posterior bulging pressing against the rectum is a rectocele, presenting with bowel issues like constipation or the need to splint to defecate. Here is a major exam anchor for you regarding pelvic alterations: continuous leakage. If a patient reports a continuous leakage of urine or stool through the vagina, this points directly to a genital fistula. This completely differentiates it from the stress incontinence of a cystocele, and it immediately shifts our nursing priority to aggressive skin protection, infection prevention, and getting a surgical referral. Which brings us to Section 3, menstrual cycles and menopause, where we'll be untangling these common alterations. Rule number 1 for any reproductive age client presenting with amenorrhea, which is the absence of menses, or abnormal uterine bleeding, a pregnancy test always comes first, every single time. Only after we rule out pregnancy do we move to the long-term workup for things like endocrine issues or polycystic ovarian syndrome. Also, if they have excessive bleeding causing dizziness or tachycardia, stabilizing their circulation comes way before any diagnostic testing. And for conditions like endometriosis, where ectopic tissue causes cyclic pain, remember that it's a major factor in infertility that requires proactive fertility-aware planning. Now, as patients transition through perimenopause, they face fluctuating estrogen levels that cause hot flashes, bone loss, and unfavorable lipid changes. But remember this core rule: menopause is officially defined only after 12 consecutive months without a period. We must never just brush off symptoms as just menopause, especially postmenopausal bleeding. Any bleeding after that 12-month mark is totally unexpected and is a glaring red flag that requires immediate evaluation for endometrial malignancy. Let's jump into Section 4, navigating infertility management using a couple-centered approach. When working up infertility, a sequential couple-centered approach is vital. Because infertility isn't just an individual problem, it's a couple's challenge. We have to evaluate both partners at the very same time.
We always start with the least invasive tests, like a simple semen analysis for male factors, before moving on to evaluating ovarian reserve or performing imaging for tubal and uterine factors. As clinical detectives, our role is to provide neutral information and ensure we never inadvertently blame one partner during the whole evaluation process.
Next up is Section 5, reproductive infections and STIs, which are serious systemic threats. Catching these early literally saves fertility. Chlamydia and gonorrhea are often completely asymptomatic early on, but left untreated, they can ascend to cause pelvic inflammatory disease, or PID. PID is dangerous. It causes chronic pelvic pain and significantly increases the risk of ectopic pregnancies and infertility. Syphilis starts as a painless chancre but turns into a dangerous systemic disease requiring penicillin. Trichomoniasis presents with a specific frothy discharge and a strawberry cervix, while herpes shows up as painful recurring vesicles. Across the board, prompt treatment of both the patient and their partner, along with abstinence until treatment is complete, is essential. You've absolutely got to know the TORCH acronym for maternal newborn health. These specific infections, toxoplasmosis, other infections like syphilis or parvovirus, rubella, cytomegalovirus, and herpes can cross the placenta. Prevention and early recognition of these specific infections is a game changer. It significantly reduces the risk of catastrophic fetal loss, severe growth restriction, congenital anomalies, and neonatal illness. And finally, Section 6, interventions and nursing care, focusing on holistic and pharmacological action. So what does applying the nursing process look like in the real world? It means practicing trauma-informed pelvic care. We explain every single step, actively obtain permission, rigorously preserve privacy, and firmly establish that we will stop whenever requested, unless immediate, life-saving care is happening. We are there to actively protect client autonomy during intimate care and to use teach-back methods to confirm they truly understand their diagnosis and treatment plan. For medication safety, especially with combined estrogen, progestin contraceptives, burn the ACHS acronym into your memory. Severe abdominal pain, chest pain or shortness of breath, a severe headache, eye or vision changes, and severe leg pain. These are not normal side effects. They signal serious, potentially life-threatening thromboembolic complications, like a deep vein thrombosis, pulmonary embolism, or a stroke. Notice how both estrogen, progestin, and tamoxifen carry major thrombosis risks. Combined oral contraceptives should be avoided in patients who smoke and are over 35, or who have uncontrolled hypertension. Similarly, tamoxifen, which blocks estrogen to treat breast cancer, actually increases the risk of thromboembolism and endometrial cancer. This reinforces a crucial clinical rule. The safest therapy must carefully match the patient's exact diagnosis, their specific contraindications, and their family planning goals. We don't just treat the symptom in isolation. So to wrap up this explainer, here's my challenge to you. How will you apply this master priority in your next clinical shift? You now have the tools to differentiate a benign fibroadenoma from a suspicious fixed mass. You know to look for subtle cardiac cues in women, to prioritize a pregnancy test for abnormal bleeding, and to protect your patient's autonomy through trauma-informed care. Become that clinical detective who spots the dangerous cue before it ever becomes an emergency. That is how you preserve both the immediate life and the long-term health of your patients. Keep analyzing, keep questioning, and thanks so much for exploring this with me today.